Good evening, delegates and participants. Thank you for joining Shield Connect. So today we are back with Karnataka College of Obstetrician and Gynecologist organized international academic program. And today's topic is mastering superovulation strategies for optimum ICSI result. So let me introduce Dr. Hima Divakar ma'am. So 1 minute. So, Dr. Hima Divakar ma'am is the medical director of Divakar Specialty Hospital, senior consultant, CEO and chairman of Asian Research and Training Institute for Skill Transfer, and dean of KCOG, vice president of Karnataka AHPI, chair of Well Women Healthcare at FIGO, president of DIPSI, ex-vice chair for FIGO, PNCD committee, past president of FOXY 2013, advocate for delivering quality healthcare, convener, Manyata, an opinion leader and influencer for social and legal issues relating to women's health. Ma'am has been also awarded with the FIGO Women Achievers Award 2015, Global Asian of the Year 2018, CME Excellence Award for Artists, Next Brand Award for Artists for her, CSR Times Award, CSR Impact Award for Divakar Service Trust. So I welcome Dr. Hima Divakar ma'am and I will hand over the session to ma'am. Thank you, ma'am.
Thank you, Nishant, for the consistent and constant support to the international series of programs by the KCOG. We have a very distinguished guest here with us, Professor Ahmed Galal from the Upper Egypt region, whom I have been in touch with only in the last couple of months, but it looks like we've been connected through the ages because the wavelengths, the intent, the sincere commitment to the cause of women's health, we touch the chord immediately, and I'm happy to welcome our distinguished guest as our international speaker today. But before we begin, may I have a few words either from Dr. Bharti Rajshekar, who is the secretary of KASOGA, or Dr. Vidya Bhatt, who is the secretary of the KCOG, please. Bharti or Vidya?
Vidya ma'am is present there. Vidya ma'am.
Is there an issue with the connectivity, or she's?
Maybe there is connectivity issue.
Okay. I think there is an issue with the connectivity. She may have stepped out for a few seconds, but in the interest of time, I will let the office bearers. Yeah, Vidya, I think you're muted, Vidya.
I'm there. Only thing I can't hear. There's some problem with the network.
Okay. I just wanted you to, you or Bharti, to make opening remarks. That's Dr. Bharti Rajshekar for you. Yeah. Bharti?
Ma'am, thank you for.
I think Vidya is frozen again. Can you not hear me?
And getting an outcome through the ICSI and then getting pregnancies. So it's a big challenge. We would like to listen to you, sir, about the tips and tricks of ovulation induction and superovulation. Dr. Bharti, you would want to add something?
I'm sorry for joining late. Welcome, Dr. Ahmed Galal, to the Karnataka State OG Association platform of KCOG. We are indeed anxious to listen to you because, as Vidya said, the IVF specialists want to optimize results, and you are here to enlighten us over here today. Over to you, sir. Thank you.
Yeah. Just before Professor begins, may I have the pleasure and privilege of formally introducing Professor Galal. Beyond being a very beloved friend in the short-term association that we have had, he stepped into the Well Women Committee of FIGO as an associate member, but believe me, ladies and gentlemen, his contributions, his thoughts, his concepts, his ideas, and his way forward vision for the well women healthcare is way beyond the couple of months that he's been associated with. And we do hope to continue a very long-term association with Professor Ahmad Kalai, who is a professor of obstetrics and gynecology at the Alexandria University at Egypt, and a lead consultant reproductive medicine and infertility, chairman of the Well Women Health Promotion Society, through which he offers a range of services, including skill transfer to all levels of frontline healthcare providers. He's the director of the Alexandria Medical Training Center, scientific director of the RIPRO IVF Center, and associate member, as I said, of FIGO Well Women Healthcare Committee, which I chair. So that is what has brought us in closer connection. Today, he will be the sole keynote speaker on the topic of mastering superovulation strategies for optimum ICSI results. And what better than to have the master himself to deliberate on this? His clinical experience extends over a vast period of time, excellent standing and performance in the field of assisted reproduction with more than 20 years in this field, excellent standing and performance in the reproductive genetics domain, and excellence and performance in fertility preservation management options, and experience in performing diagnostic and operative laparoscopy, as well as both diagnostic and operative hysteroscopy in all reproductive indications. He was awarded the Best Research in Innovation of Infertility at the International Congress of the Egyptian Society of Fertility Sterility in 2011. He is also the official representative of Mediterranean Society of Reproductive Medicine in Egypt. And today we have the great pleasure of listening to the experiences shared by Professor Ahmad Kalal, and to imbibe the knowledge and the wisdom from this great master on the superovulation in the ICSI processes. So over to you, Professor Ahmad Kalal. Welcome again to the forum in India through the Karnataka College of ONG.
Thank you so much, Dr. Hima, for the introduction of me. This is a great introduction. And thank you for all the stuff I am joining today. It's my pleasure, actually, and my honor to join for these very unique scientific, updated, high level of scientific events. So, So to start, let me thank you, all of you, actually, and one of your, maybe the representative of you, Dr. Hima, as she said, actually, is that we already have met a couple of months ago, but actually I felt like we know each other from a long period of time, because we have shared a lot of thoughts, a lot of plans, and a lot of activities actually for the coming years. So actually, it is the same like we met a long time ago. And of course, also because we have a civilization actually from Egypt and in India, that how it come together and the crossing together. So let me firstly say that I am from Alexandria, which is a Mediterranean city in Egypt. And Alexandria is the heart of Egypt, actually, with many of these photos. And I am from Alexandria University, which is one of the major universities in Egypt. That's considered to be the #2 university in Egypt regarding the number of the students and so on after Cairo University. Let us say firstly, hello by all language, and specifically hello by the Indian language. So hello for every person joining us today.
Thank you.
Then have the basic knowledge that the first successful IVF pregnancy resulting from a spontaneous cycle. But after this spontaneous cycle, actually, there is the terminology that was called the controlled ovarian hyperstimulation that is routinely employed to give a multifollicular growth. However, this terminology is removed nowadays, and it is of ovulation, superovulation techniques, or ovarian superovulation techniques. So what you need actually protocols for ICSI. Firstly, we should differentiate between induction of ovulation, that is the idea to give one or more follicle for the purpose of induction of ovulation to get this one that is used actually for the cases of the maybe the ovulatory disorders, and maybe the male factor infertilities, maybe some factors of augmenting the ovulation in a simple way, for the simple way or for the IOI. Or the other one, which is a superovulation technique, in which we have many follicular growth or multifollicular growth with different sizes, and the maturation of the follicle to be picked up for the ovum pickup and then the ICSI procedure. In the superovulation, which one is better for you? Is that to go with this picture or to go with that picture? Of course, many of us will not go through this picture because it's ovarian hyperstimulation syndrome, which is one of the dangerous one, and many of us will go to this picture. So how we can go to this picture actually, and what is our aim? To have like a single baby like that one, or a twin, or a triplet. Definitely triplet have a major problem, and the triplet considers as a complication. Twin pregnancy considered complication in some areas of the world, in other areas not considered so much complication, but still this have a burden on the mother and on the community as well, and on the neonatology and so on. So it's better to go to this one. So our aim now is to have a superovulation that is away from the ovarian hyperstimulation, and at the same time ending by a single viable healthy pregnancy. This is our aim for the IVF practice in general: single pregnancy without cycle cancellation and without ovarian hyperstimulation. That's considered to be in the severest form 2%. However, this 2% can be fatal for the patient. So just to inspire the nature, just to inspire some of the attention, then we'll go through our journey. So the aim of our presentation today is to have some mastering of the techniques for the IVF procedures. So what will be done and what should be avoided to be done. So number one, it is the assessment of the predicted response of ovarian stimulation is sufficient to be reliable. What are the tests that we should consider for assessment for ovarian stimulation and the assessment of the dose? These all the variables that we have: the intrafollicular count, the anti-Mullerian hormone, the basal FSH, baseline inhibin, the age of the woman, the body mass index, the basal estrogen. And we will have three colors in the next typing. The green one means that it is a good. The red one means it to be avoided, and the blue one means that we may consider it or not according to further research. So the reliability of the intrafollicular count alone is not is sufficient. So we can consider the antifollicular count alone. We can consider the anti-Mullerian hormone alone, but we can't consider the p-inhibin alone, or the estradiol level, or the age alone. So now the two factors that we already picked from all these lists is the anti-Mullerian hormone and the intrafollicular count. Each of them can be one of the criteria. So let us go more deeply for the anti-Mullerian hormone as an example, and the intrafollicular count. The antifollicular count is a simple way that you can do by the ultrasound on the two aspects of the ovaries, on the right and the left, and you can assess how many follicles you have for the intrafollicular count. This is a very reliable and at the same time a very simple, cost-effective way, so it needs no extra cost. But the anti-Mullerian hormone is not a routine using for the IVF practice. Suppose you have a good responder patient and you find a good number of antifollicular count, so you are not in need for prescribing or asking for the anti-Mullerian hormone, because at that time it will be costly. But you may need the anti-Mullerian hormone in a poor responder patient to have your documentation of what is the level of the anti-Mullerian hormone that you will start in your stimulation or cancel the cycle accordingly. At the same time, you may need it in the patient of PCO patients, because sometimes at a certain level of the anti-Mullerian hormone, the stimulation doses should be increased, and we be aware of the ovarian hyperstimulation syndrome. And at the same time, it may be used in some cases for documentation of the results alone. So depending according to every country practice. But to have a golden marker, consider these 4 elements. Number 1, the previous response, which is a major teacher for us, is a previous response. If it is done with an expert person, so the previous response is very good. Don't ignore any poor responder in a previous response. If the patient have, or didn't ignore any hyperstimulation. If the patient have any hyperstimulation previously, don't start with the same dose. No, go with the lower doses to avoid the hyperstimulation syndrome. Take care of the age, irrespective of the number of the intrafollicular count, because the age have a many implementation on the response as well, and then consider the antifollicular hormone and the anti-mullerian hormone. So it's a mix between the 4 aspects of them to have the goal, the status of your patient from the start to have the response rate. Then, what is the prognostic value for the hormonal assessment as a baseline? It is good to have a basal hormonal profile or not. Actually, of the studies saying that there is no need either for asking for the estradiol level, or for the progesterone level, or for the FSH or the LH level. So consider asking for them only if you have a rationale for asking for these hormones. But for the simple way of ICSI production, it is not necessary to have a hormonal profile for the patient. Then, after taking these basic concepts, we will go to the basic rationale behind the superovulation. What is the basic rationale for this one? The rationale for this one is actually the period of, it's a physiology where it is in the luteal phase and the follicular phase, where the response will take place from this one. So consider this with me. This is a normal growth of folliculogenesis, starting from the primordial follicle until the pro-ovulatory and then the ovulatory follicle later on. We have here 2 categories of, this one is not in our domain, but this one is a gonadotropin responsive and this one is a gonadotropin dependent. So when you see this item, actually, you will find that your dose of the gonadotropin should be taken in this area, because in the starting area here, you will recruit a lot of patients. Let us go more in clarity. So this is how the hormonal profile changes with the cycle. And if you can see here is a FSH level increasing and the E2 increasing until the surge. But what is the importance here is a period of here, the starting period of recruitment. So this is a recruitment. Consider it like as you are offering a food for a number of people. If you offered a small number of food or a small volume of food, a small number of the people will eat. But if you offered a lot of food, so a lot of number of people will eat. So it is the same like the follicle. If we have like a hormonal profile here is less, so only 1 or 2 follicle will grow. But if you have a lot of hormones in this period, so a lot of follicle will grow actually to the maturity. But be careful about what is the number basically here to be started with and what is the number you will reach on. And this is one of the tricky points, because if you find that you have an intrafollicular count, let us say 10 intrafollicular counts, if you achieving 7 or 8 from this intrafollicular count, which is 75% of this one, to be a mature follicle, you are in a good status. If you're achieving less, you have a problem with your stimulation protocol, of course. If you have more, so this means you didn't see a lot of the follicle in the pre-intrafollicular counts, and so you're missing the number, and you can surprised with the ovarian hyperstimulation syndrome. And this is how the hormonal changes. So increasing the length, increasing the period of the FSH window, increasing the timing and the dose you will give it, it is a crucial part. So please start early. So it's advisable to start all your stimulation, whatever you are going with the agonist or the antagonist, in the early days of the cycle, not after this one. And especially it is evident when you are dealing with a cycle that is not suppressed. So in a normal cycle, if you are started as an example on day 6 or day 7 or day 5 or something like that, there will be a problem with your recruitment, because some follicle will already started to grow, and any dose you will give increasing the size of this one, not increasing the number later on. Then we will go to the ovulation induction medication. The ovulation induction medication, we have the anti-estrogen, such as the clomiphene citrate, tamoxifen, Nolvadex. We have the aromatase inhibitor, first, second, third generation, and the gonadotropin, which is maybe urinary, highly purified urinary, and the recambrant, and then the GnRH agonist and antagonist medication. Then we have some adjuvant for the ovulation induction, like the metformin, acetylcysteine, estrogen, growth hormone, corticosteroids, dihydroepiandrosterone, vitamin D, and the other vitamins. So a lot of adjuvants that can be, some of them can be used. So just relax. We will go in depth for the stimulation protocol itself. So these are the whole protocols that we have, and consider the induction of the ovulation or the superovulation in general to be in two categories majorly: the non-gonadotropin releasing analog and the gonadotropin releasing hormone analog. In the non-gonadotropin releasing hormone analog, we have like the clomiphene citrate only or other anti-estrogen, or the clomiphene citrate combining with the HMG or the gonadotropins. And the gonadotropins, we have the chronic low dose and the conventional low dose. And these chronic low dose, we have 3 types of them. And then the agonist and the antagonist protocol, which is a gonadotropin analog. What is the difference between these two? The difference here is the pituitary downregulation. So in the non-analog, we are starting with a simple cycle without any downregulation. And here we downregulate the cycle either from the start with the agonist or from later on, from the start with the antagonist or from the middle or the before the starting of the cycle with the agonist itself. So this is a major protocol that we have, and we will go through each protocol, and then we can ignore some of them, simplify the situation with 2 or 3 protocols roughly by the end of this one. So to start, actually, this is a gonadotropin name for all the hormones that we have worldwide, whether it is a human menopausal gonadotropins or a purified HMG, purified FSH, GnRH agonist, antagonist, recambrant, urinary HCG or recambrant HCG. So this is the players that we are playing with in the medication itself. So firstly, do we need to do some hormonal pre-treatment for the cycle to improve the efficacy or not, such as to add estrogen pre-treatment? Estrogen pre-treatment has no effect on the ICSI cycle, so no need for giving estrogen in the pre-treatment of the cycle. The same applied for the progesterone. And for the combined pills, there is actually in the combined pills, it's not recommended as a whole for the antagonist or even for the agonist cycle. But actually, if you need it, we have 2 factors for, we have 1 indication for it, which is the cycle adaptation, or let us say the scheduling of the cycle. This scheduling of the cycle may be for the benefit of the patient or for the benefit of the physician, but it is allowed. But if you do this one, actually, you need to do something which is very important, is to have a pill-free 5 days at least, pill-free period 5 days. So don't start any stimulation or any start of the stimulation before 5 days of stopping of the pills. If you started this before 5 days of the pills, you will have a reduction of the pregnancy rate, and you will have a negative effect of this one. So you can start the pills, whatever the duration you need, until 1 month before, and then you can withdraw these medications and then go with the stimulation 5 days later. And actually, in practice, when you stop the pills, you will find yourself to have like 3 to 4 days until the cycle will drop down, and then you will start 1 or 2 days later. So it's a 5 to 6 days old. The antagonist in the pre-treatment is also not recommended for the starting of the stimulation. So for the non-analog protocol, it's simply a patient come to you in a menstruating cycle, and you start the HMG, whatever then the type of the HMG, at the start of the cycle. So you will give the prescription of your hormonal medication, which is FSH or HMG, day by day, according to the doses that you are adjusting, and then you follow it. This is a simple protocol. It's the non-conventional, the conventional way of them. But we have a problem here that we started actually as it is. So we have a problem with asynchronization of the follicle. We have a problem in the spontaneous LH surge, which happen in 1/3 of the patient, and the premature luteinization is another problem. So this protocol, if you are considering this protocol for your action, actually you can consider that your pregnancy rate is lower because this protocol gives about 25 to 30% pregnancy rate with the best hand. So it's a lower limit. Although on the other side, it's a cost, if it's a low cost protocol or a patient-friendly protocol because you don't give a lot of medication for the patient. You can start by 150 to 125 according to the patients, and then you can follow the patients. But prepare yourself to often pick up at any days of the week, because you will have like an LH surge that emerges actually to go with the oven pickup because of increasing the hormonal profile. If we go back here, actually for the clomiphene citrate and the clomiphene citrate with the HMG, clomiphene citrate alone is not indicated actually for the cases of the ICSI, and I don't like the clomiphene citrate with the HMG actually because also it yields a low results for them. So let us concentrate on the gonadotropin only protocol, and this is the conventional one. The low doses one actually is not suitable for the cases of ICSI also, except if you started with a higher dose of them. And this simplifying that it is maybe starting with a larger dosing, then going down, or with a small dose that go up according to your protocol. So it's better actually to go with the non-analog conventional one if you use a non-analog protocol, but consider the problems with this protocol and the lower pregnancy rate as well. Then if you go to the analog protocol, we have a two analog protocol, the agonist or the antagonist protocol. And in the agonist protocol, we have the ultra short protocol, the short protocol, the long protocol, ultra short, ultra long protocol. And these long protocol have a one follicular and one luteal protocol. So if we started how we can do this one. Ultra short protocol is that we give like a dose, like a flare protocol. So we give like a general agonist on day 2, 3, or 4 only of the HMG, and then we stop it. We continue with the stimulation as we said. In the short protocol, we give it from day 2 to 3 until the day of HCG. And these actually two protocols, the microflare protocol and the short protocol, actually proven to be more or less lower, has a lower pregnancy rate rather than the standard protocol. So actually ignore these two protocols because they are not so much important in our field of discussion. So in the long agonist protocol, which is the third one, the long agonist protocol, we have two types of the long agonist protocol. You can start it in the mid-luteal phase, which is the normal one, or you can start it in the follicular phase. Let us describe the follicular phase and then ignore it. The follicular phase is you can start with, firstly, you can give 5 days of pills, and then if 5 days combined pills with a gonadotropin releasing hormone agonist, and then remove the pill and continue with a gonadotropin releasing hormone agonist. So you are taking 10 days of pills and 10 days of gonadotropin releasing hormone with overlapping 5 days in between. This protocol was to some extent sufficient in a couple of years ago, but actually these days the results are very lower compared with the other protocol of the antagonist protocol. So it was like in the era before the antagonist protocol. So ignore this one. But now consider the long agonist protocol. In the long agonist protocol, you started in the mid-luteal phase. So you start in the mid-luteal phase with suppression of the cycle. And once you have a suppression imminent, which is a 4 criteria or 3 criteria plus or minus the fourth one, the presence of a quiescent ovary. So the ovary is a quiet, there is no excessive or marked growth of a follicle. The endometrium is thin endometrium. menstruation maybe or may not, and the E2 below 50 milligram. So if you consider these 4 items, actually, you will have the patient suppressed, and you can start your stimulation agency after this with reduction of the GnRH agonist until the day of HCG, and then you can trigger the patient as usual. So this is a long agonist protocol. The tricky point in the long agonist protocol is you should start actually in the mid-luteal phase. It's very, very important, and the suppression criteria is another area. If you are starting your career in the IVF practice, actually long agonist protocol is the one that considered to be the standard one, because this one, if there is any fault or there is any delay of the ovum pickup, can be compensated in the long agonist protocol. Then we will go to the antagonist protocol, and in the antagonist protocol, we have actually 2 antagonist protocol with maybe a single dose antagonist protocol or a multiple dose antagonist protocol. The more familiar is a multiple dose antagonist protocol that may be fixed or flexible, and the more familiar now is a fixed one rather than the flexible one. What is the difference between all of these? In the multiple dose protocol, we start the cycle with after the withdrawal of the bleeding, and then we start getting the induction, the stimulation of the HMG and the FSH or a combination, whatever. And then on the 5th or days of the stimulation, which is considered the whole mark of the stimulation story in the 5th day of stimulation. So on the 5th day, you consider adding the antagonist protocol, such as a cetrotide or cetrolex in this area. And then you will continue with this dose actually until the day of HCG. In the fixed one, you started at the day 5, irrespective of the size of the follicle, except if the size of the follicle is very, very low, so there is no stimulation happen to the ovary. You can extend it for a while. But in the flexible one, you will start the antagonist actually on the days on this follicular size of 14 or more. So this is the major changing of it. If you are mastering your practice, so starting with the fixed protocol rather than the flexible protocol, because this will allow more standardization according to the days, not according to the size that may be variable between the physician. In the single one, you can give 3 milligram of subcutaneously of the antagonist protocol, the long-acting one, and you can consider it again on day 9 if you have like 3 to 4 days, 4 days after this day without any until you're reaching the HCG criteria. So by this means, actually you can go with the with a single dose protocol. Which is better actually for the single dose protocol or for the multiple dose protocol, according to what you are mastering and what the medications you have. So if you have a single dose and you are mastering a single dose, there is no problem for doing it, or for the multiple dose. So at the end of these protocols, actually, we now have like, if you are dealing with the analog or the non-analog, the non-analog considers that you will have a lower limit of the pregnancy rate, consider you will work at any time, and you may lose your cycle. These are major 3 elements. On the other side, in the analog, we have an agonist and antagonist protocol. If you have the antagonist protocol, you can do with a fixed antagonist protocol, multiple dose. If you go with the agonist, the long luteal agonist. Of course, we didn't mention the ultra-long protocol here because this one was proposed actually for the cases of endometriosis, but nowadays there is a recommendation against it because actually it suppresses the cycle, the ovary very, very much, because it suppresses the ovary for more than 3 months until stimulation after doing the endometriosis treatment. So it's not actually one of the recommended. So consider now the long luteal protocol for the agonist and the antagonist protocol fixed multiple dose protocols is after. If you are in the beginning of your career, concentrate mainly on the agonist protocol. If you are more expert, you can go with the antagonist protocol. There is a shift worldwide towards antagonist protocol rather than the agonist protocol nowadays. But actually, the effect in the antagonist protocol can be compensated. So as an example, if you see the patient and you are hesitating between ovum pickup or not, trigger or not at this time, in the antagonist protocol, please trigger in the agonist protocol, you can wait for a 1 day with no problem. But if you waited this 1 day for the antagonist protocol, you may lose your oocyte quality and cytoplasmic abnormality. So which protocol can you use actually in any responder, which is agonist or antagonist, mild stimulation or natural cycle? So in the higher responder, agonist and antagonist is the same, so you can use both of them without any problem. And the mild stimulation, however, the antagonist is more safer than the agonist in this way because it avoids the hyperstimulation syndrome. The mild stimulation is not for the cases of higher response, but for clomiphene citrate and the aromatics. Reduced dose is not recommended so much from the start, but it can be reduced at any time actually to decrease the risk of is not one for the hyper responder. In the normal responder, can we use the antagonist or can we use the agonist? Both of them is okay, and the antagonist can be more safer in some conditions. In the mild stimulation is not recommended, and the reduced dose is not recommended also for the hypernormal responder patients as well. The letrozole addition to the stimulation protocol is not recommended for the predicted poor responder patient as well. So the poor responder patient, what is the dose that you can give for the patient for the gonadotropin? It's starting from 150 to 300 international units, and if your dose are more than 300, because more than 300 you will have a side effect and you don't have any more oocyte yield actually for this one. So which LH suppression or which is a pituitary suppression or pituitary control protocol is preferable, agonist versus antagonist, as we said, depending mainly according to what is the situation for patient. It's a higher responder, it's a normal responder, it's a poor responder patient. Then we will go to the medication itself, the gonadotropin medication. Is there is any superiority? Can I use the recombinant or use the urinary or the purified urinary or the highly, the combinations or whatever? So actually many statements coming from the HRE and from the SRM saying by the end of these all statements actually that there is no evidence that any of the medication of or any of the hormonal preparation is superior to the other. So if you are using the recombinant, it is not superior than using the urinary, and the urinary is not superior than using the highly purified urinary. So whatever you are dealing with, the most important is the quality of your medication and the dose adjustments that you are doing. So there is no problem to use the medication and consider the cost effectiveness of the cycle because it's a trial by the end of the day. Then the gonadotropin adjustment is not actually recommended for the cases of mild stimulation. It can be recommended actually for the cases of hyper responder. We are going to some of the adjuvant like the metformin as an example. Use of metformin is not recommended with the patient for the polycystic ovarian patients in the context of ovarian hyperstimulation prevention. Can be used for the PCO patient in general. The growth hormone is not recommended for the poor responder. Testosterone is not recommended in a poor responder. The dihydroepiandrosterone is not recommended also for the poor responder patient, and the aspirin is not recommended at all for any population, any general population of the IVF and the poor responder. The sildenafil is not recommended also for this one. So why I came with these adjuvant, because many of our physicians in many parts all over the world using some of the adjuvant for the patient, and actually the evidence behind using this adjuvant is lacking. So please consider the cost effectiveness, the side effects of these medications, and at the same time there is no evidence supporting you to do all these adjuvant treatment. So whenever you are being the more simplified and the more in concentrating on the basic physiology and then adjusting yourself to this basic physiology to better results, actually this will end with a good result and a higher pregnancy rate for you. And consider all the time that the first pregnancy from the IVF cycle was from a natural cycle, not from any other cycle with all these adjuvants. Then can we start the ovulation stimulation randomly at any time of the cycle? Actually, the recommendation is against this one, except in one case, which is the situation in oncofertility, in which there is no time actually for fertility preservation cycle to be postponed. So in this way, you can give the random start of this one, because you will give the ovum pickup and freeze the embryos after that, or freeze the oocytes according to if there is a husband or not. Double stimulation protocol in a poor responder should only be used in the research context only, and for the urgent cases can be considered at some time of this one. So again, to summarize this area actually is that you have, if you are dealing with a protocol, you have a non-analog or analog, and then you can decide with which one you will doing with. Then for the gonadotropin preparation, any preparation that you can use is effective. What is important is to have a little LH with FSH. So consider not giving the whole story of the FSH alone, because this will affect your results very much. Some of the clinical scenarios, and this is the last part of presentation, because we find these scenarios that actually going with some of the stimulation of your patient, and so you can deal with it very much. Number one is a polyp. Is a polyp before stimulation or during stimulation. The tricky point in the polyp is to wait until you see the polyp in the immediately post-menstrual. And if you see the polyp immediately post-menstrual, I think you can go with hysteroscopy to remove it before starting your stimulation. Or if you found that the polyp during stimulation, you can go ahead with your stimulation. And if this polyp is a small polyp like ½ centimeter or less, or up to 1 centimeter, you can go ahead with all the procedure and the embryo transfer and so on. But if you have a polyp more than this 1 centimeter, you should remove it. So at this time, you can do the ovum pickup, you can do the fertilization and then embryo freezing, and then remove this polyp on the next cycle and then transfer in a frozen cycle later on. The ovarian cyst. Ovarian cyst actually is one of the challenges that we are facing, because we can see the ovarian cyst before or after the stimulation. We are conducting what we can do for the ovarian cyst. The major challenging point actually is what is that ovarian cyst, and we have a complete actually picture, because we are, as a reproductive endocrinologist, usually see a lot of ovarian cysts before stimulation or during stimulation, and some of these ovarian cysts actually is a sort of a borderline ovarian tumor, and sometimes it may be an overt malignancy of the ovary that shouldn't be missed actually for this patient. So one of the simplest way actually to go with is to go with the IOTA system for the simple ultrasound rules for the general doctors. And we have like a feature of a benign and a malignant. So we have one of these 5 features can consider the mass as a benign mass, which is a unilocular cyst, which is a presence of a solid component less than 7 millimeter, presence of acoustic shadowing, or presence of no blood or minimal blood flow, or the cyst is less than 10 centimeter in dimension. So it is a benign feature. On the reverse of that, if there is a hypervascularity, if there is a multiple solid component, ascites, more than 4 papillaries, and the irregularity of the mass and solid component of the mass is or more than 10 centimeter, this is considered as a malignant feature. You can combine if it is 1 or 2 malignancy without benign, so it's a malignant lesion, or 1 or 2 benign without malignancy, it's a benign lesion. This is a simple way, but actually, because this is not our topic today, but there is another one, which is the ORAD system for the classification of the ovarian masses. But this is very important if you feel or if you see like a cyst when you are dealing with ovarian stimulation and at that time you are actually going to manage this cyst. You can manage this cyst with an expectant way, or you can manage it by surgical way. So if you have this cyst from the start and this cyst is like less than 6 centimeters in dimension, you can wait for 1 or 2 months and then you can find if this cyst cleared or not. If the cyst is cleared, so go ahead with your stimulation. If the cyst is not, go ahead with the laparoscopic removal of cystectomy. If you find this cyst actually during your stimulation protocol and you are confident enough, or you are more or less feeling that the cyst is not a malignancy, so actually you can do cyst aspiration only for the purpose of decreasing the size of the cyst and allowing more spaces for the ovum for the follicle to grow, and then to allow you for the ovum pick up. But it is not a final treatment. It's only a transient treatment for this. So to conclude, ovarian induction is an art. Super induction for the cases of ICSI is an art of how you can deal with it. Every treating reproductive endocrinologist should be aware of the medication used and also the associated conditions that you may encounter, and you can deal with it very probably. The individualization of the treatment protocol is the most crucial concept in conducting our super stimulation and in ending by pregnancy rate and the success of the cycle very much. So it's a tricky point, but actually it's a good actually to deal with the patient in this way on and that way. And then by the end, thank you so much. And this is just the beginning of a collaboration, and every ending is really just a new beginning. Thank you so much.
Thank you so much, Professor Galal. And like a wise man, after talking so much of science, you concluded that it's indeed an individualized art to make things more successful than the usual. If you could kindly stop sharing your slides, I would want Vidya to raise some questions first. And we have plenty of questions from the beloved audience as well, hundreds of them who are watching you right across the country. So first, you go ahead, Vidya. Thank you so much, Professor Galal, once more.
Thank you.
Thank you, sir. Thanks for that brilliant illustration of ovulation, of course, of the ovum, and then the ovulation induction, and then when to do what. But still, as you learn more, you have more curiosity. So we have some set of questions for you. Sir, you told about the different protocols, that is the long protocol and then the ANTAC protocol. In endometriosis, the classical teaching, what we hear is use an ANTAC protocol. But what is your take? Is there any role for GnRH agonist protocol? Because sometimes we give a GnRH prior to the stimulation. Will it act as an other antagonist action when we give GnRH agonist protocol?
Okay, thank you for this very crucial question. For the endometriosis, actually, for many years ago, we supposed to use the ultra long protocol, but nowadays is ultra long protocol, which is ultra long agonist protocol. But nowadays is ultra long agonist protocol is not considered the golden standard for it. So when we are using the agonist or the antagonist, the evidence and also the practice saying that there is no difference if you are using any of them, because it depends on what is your primary treatment of the endometriosis. If you are going with a surgery, then doing the ICSI, or you are going without surgery and doing the ICSI. So by the end of the day, it's not different to go with the agonist or antagonist.
Thank you, sir. Thanks for that clarity, because there is a lot of confusion in everybody's mind that should we use an agonist or an antagonist protocol, and then the classical teaching. Thank you so much. Sir, is there a role of minimal stimulation in PCOS? Because we are more worried about the hyperstimulation, and sometimes when we start with the low dose, the patients may not respond. So what do you think? Do we have to start with the low dose, or we start with the normal dose and step down would be better in PCOS patients?
Okay, so you are dealing with a non-analog or are dealing with analog with the starting dose? Which one?
GnRH antagonist protocol we use always, but we are always worried about hyperstimulation when we take a PCOS patient, because we always feel if you lower, then she may not respond. If you give a higher dose, she may go in for hyperstimulation.
Sure. Okay, so as I mentioned earlier, that AMH is one of the let us say a good test for the PCO patient, because if the PCO patient have an anti-mullerian hormone more than 9 or 10, they will not respond actually on the lower doses of the stimulation. So you will elevate the dose from the start, and at the end you will anticipating the presence of ovarian hyperstimulation syndrome. The situation here is that there is a threshold for the stimulation for any patient. For the two patients, the variable, and this variable is not actually reached until you will try. So in the normal PCO patient with a normal anti-hormone in 5, 6, 7, something like that, I will start by 150 to 225. Will not increase rather than this one. If the patient have like anti-mullerian hormone, which is a higher hormone, I will start by 220 or 187.5, and then will increase the dose according to the response. But in all PCO patients, we may anticipate the presence of some sort of mild, moderate hyperstimulation syndrome, and depending on your response. Another important issue is that body mass index of this patient, because usually the tricky one will be in the obese patient rather than the lean patient, especially with the insulin resistance. This can bring a lot of this. So in my practice, as an example, I do weight reduction firstly. If I have like a 10% weight reduction from this patient, this will give a good result, decreasing the hyperstimulation syndrome.
Thank you, sir. Thanks for the point of first is AMH levels, and then the weight reduction, and then the starting dose, which you said in PCOS patients, which is very crucial for us to understand and start a protocol. So what is your protocol in poor responders? Do you start microflare, or do you give full cycle IVF, or you want to just do with letrozole oral ovulation induction?
Okay, for the poor responder, I have two elements, two tricky points. The first point, I will counsel the patient that I will not start until I have 3 to 4 follicle on each or on both sides. So this means that the anti-follicle count from the start, I have 3 to 4, so I will induce at that time. If there is no 3 to 4 at that time, I will postpone for another month, and so on, because it's a recruit, it's a pool. So this pool, if I have like a 1 or 2, I will may get nothing or 1 or 2. But if I have 3 or 4, I can get some more 1 or 2 or no. This is number one. Number two, I started actually with 1 of 2 protocol. To be basically, I will start with the antagonist protocol, the flexible antagonist protocol. Sorry, the multiple dose fixed antagonist protocol. This is the one I am using in this one. A good result or a better result rather than this one of the microflare protocol. I can go to the agonist protocol in one situation only, which is a situation of asynchronization between the follicles. That's common in the old age group. So in this way, I go with the agonist protocol, but I do what is called the agonist stop protocol. So I do the agonist until the patient is suppressed, and then I go with the stimulation only without the agonist. So I give a space for the ovary to be induced.
Thank you, sir, for enlightening that. Because the problem here, what we are facing is the poor responders. As the woman age or ovarian reserve goes down, and we get a lot of patients coming in that group, and then it's a big challenge to get embryos, good quality embryos in them. So do you follow freeze all, or it is case based?
Sorry?
Freeze all embryos. Embryos, do you freeze all in the cycle, and then the next cycle you give HRT and then transfer, or in the same cycle you transfer, or it is case different?
Okay. Actually, it depends on the number of the embryos that came out. If the number is sufficient, like 2 or 3 embryos, so I will go with the same cycle. There is no problem because there is nothing saying that the frozen in the old age is more better than the fresh cycle.
Okay, sir. Thank you so much for that. And then, sir, there is now a lot of hype on the progesteronized protocols. That is, you give progesterones instead of antagonists. And they say, especially in a developing country like us, they say we save a lot of money than using an antagonist. You use progesterones. What is your take on that?
Okay, actually, I used that in the last time because we have a shortage actually in the last times in the antagonist itself and the agonist as well. So we are obliged to do the progesterone prime cycle. So from the start, some of my colleagues started actually to do the progesterone from day one of the stimulation. But with my thinking, actually, I found it's not like that. So I started the progesterone actually on the day 5, the same day as I prescribed the antagonist. So starting from day 5 of the stimulation, I started the progesterone until the day of HCG preparation. Then I froze the cycle and then doing it through transfer later on. The pregnancy rate is good actually compared to the antagonist cycle. It is more or less the same. The main issue is to counsel the patient that we will not transfer in the fresh cycle. We will transfer on the next frozen cycle. Of course, it is a little bit less costly rather than the agonist and the antagonist.
Okay, sir. Thank you. Because we would like to know your experience and how is the pregnancy rate, sir, when you do it in the subsequent cycle?
It was like the same actually for the antagonist cycle. There is no problem actually. So it's not different. Yeah.
Thanks for highlighting that point. And last one question, sir, if Madam could permit.
No problem.
So, what protocol do you use in these cancer patients in fertility preservation? Because we have had a big challenge that we do the surgery and then before chemo we want to freeze her eggs or embryos. So dual protocols has been talked about, but what is the best to get the best quality of eggs and to freeze her embryos?
Okay, definitely fertility preservation is a major issue, but let us say on the stimulation itself, if you have the time, you can go with a usual protocol. But usually you don't have the time. You have a very limited time. So random start is one entity, and the double stimulation is another one. But what is important is the type of the cancer itself, if it is estrogen dependent or not. So if it is estrogen dependent, you can add a letrozole to decrease the estrogen level for this patient, and you can go ahead with the double stimulation. Because you are not concerned actually with the endometrium at that time, there will be no problem in the double stimulation or in the random start of them. And we found in many cases that the oocyte quality is not affected so much in response to this random stimulation. Because actually by the end of the day we have an embryos or oocyte to be frozen in this cycle. So I think both of them can be used. Letrozole adding can be another option.
Thank you, sir. Thank you so much for enlightening us on all these crucial aspects, which is controversial. There are some studies coming in, and then there is another study which comes and says, no, that is not good. So thanks a lot for this brilliant illustration of yours, and then the excellent deliberation of all the ovulation induction protocol.
Thank you, Vidya, for raising so many important practical questions, because the literature review in different groups will say different things, but a dialogue with an expert brings home a lot of insights into what really one must be doing. There are just a bunch of questions from the delegates here, more in more general terms than the specific ones which Dr. Vidya raised. One is about the whole list of adjuvants that you mentioned in one of your slides, inclusive of vitamin D. Do you really use any of these or some of these routinely as an also ran prescription? Or do you find any value in using them?
Okay, good question. Actually, for the whole of these adjuvant, I didn't use any of them. I just use the folic acid for the patient, and I use the vitamin D. The patient is deficient in vitamin D only, but it's not in a usual routine. Otherwise, I don't use any more vitamins until we're reaching the antenatal and according to the needs for the antenatal. So actually, I don't add any of the vitamins, any of the aspirin, any of the other medications for the natural cycle, for the exercise cycle. I mean,
yeah. Thank you, Professor Galal. There is one question about, even the FIGO. We've been trying to write up about FIGO recommendations for use of oral dihydrogesterone. Okay, starting from the luteal phase onwards, on and on to maintain the pregnancy as such. So there is always a concluding sentence that we need more research and we can't definitely say whether it needs to be used or not. Whereas most fertility practitioners are finding a lot of value in use of oral dihydrogesterone, both for the immunomodulation and for the role that it has in the luteal phase defects and so on and so forth. So what is your practical view on this? Because we may still have to wait long for the literature support and the evidence to be really robust. But whomever we have spoken, they say, yes, we use it. Yes, we know that there is no literature support. Yes, we know that FIGO has not yet recommended this. So what would you say on this?
Actually, I don't have a lot of experience with this one, because many of the studies, as you see it, saying that there is no rule actually for this one, and some of the studies conflicting data. I did for a limited cases in the starting of its era of using it, but I found no difference. So that's why I think that there is no evidence supporting, and there is no difference with my practice. So I stopped it. So I don't have a lot of experience with that.
Actually, I think it was Ismail from Egypt, if I'm not mistaken. It was from one of those areas that the study said it's really crucial when you start this oral dihydrogesterone. It's no use starting it after you document the pregnancy, or as in the case of threatened abortion, later it's a 6th week or 8th week. You must start it at the 12th or 14th day and continue through the luteal phase, and then ever and ever after, like until 20th week, until 28th week, then you will prevent preterm deliveries. There's a lot more being spoken about, and we really, really do need to put our heads together to see whether some more evidence can really be produced around this, because on one hand, it's rampantly being used as per the sales records of the companies who manufacture that in India. That's for sure. That is the only piece of evidence that we have got, that practitioners are actually using it, but we need to nail it down to yes or no, or maybe in some cases kind of an answer. So that still remains a gray zone. Absolutely the last question, and we'll let you go. The cost of all these procedures in your part of the world, are they covered with insurance? Does the patient have to pay out of pocket? And the more drugs you use, the more number of patients that have to undergo the ART procedures. What is the acceptance in terms of the cost? That is the one part of the question. The second part is, at least in India, we have number of so-called fertility centers, ART centers, IVF centers mushrooming. And now, as we speak, Dr. Vidya Bhatt had a deliberation just last week about the new regulations and rules which are coming out. So in Egypt, is there an accreditation mechanism or a process for anybody to kickstart their unit, or just an OBGYN who's gone here and there for some fellowship training and something done and then just starts it off? So both these, cost and quality.
Okay, two difficult questions. The first one, for the cost, in the majority of the patients, it's out of pocket. So it is it's a good amount of money. So it's not cheap actually. especially with the later inflations and so on. So it's not cheap actually to have an IVF cycle, but there is no way actually for the patient to go with anything except from her pocket of money.
Right.
There are some universities or a governmental center for the IVF, but it's not so much actually. It's again, it's with it's paid only also, but with a little bit lower cost rather than the private one. So this is the first part of the question. For the second part, which is the credential actually for conducting the credential for the physician, credential for the center, right?
Yes.
So for the center, there is a credential for establishing a center. That's to say that you have like some of the infrastructure, the places, and some of the engineering and so on. That yes, should holding actually a higher degree, which is a doctor degree in reproductive medicine and infertility and andrology, as well as embryologist as well. So this is mandatory to establish a center. But who is going to conduct his IVF practice inside the center? Some actually it's different from many parts of Egypt, but by the end of the day, there is no clear cut who is a person doing his IVF practice. That's to say, if he's specialized in obstetric and gynecology, and he do some of the courses, some of the like diplomas or something like that, he can do the IVF practice until this moment. Although we are now in a case of reviewing with some of our efforts, reviewing what is this credential, because we have a lot of IVF cycle, which is more than the needed number of the cycle for the country.
Excellent. Because, we are grappling with the same problems here, because the quality control and the accreditation process and just about anyone and everyone, you would see that programs like these, which are primarily, because on the topics that you gave, I chose this one because there's a huge demand for anything related to infertility practice, because everybody wants to snap some information from here and there, and then, just implement in their practice. So the takers are many, but how, with what kind of understanding, because the foundations that you laid in the initial part of your presentation with those slides, they need to be repeatedly recalled in the clinician's mind, because what is it that they're actually trying to fine tune, and what are these drugs doing to the system? So that often doesn't happen, and it gets erased after n number of years after your post-graduation. So that is the ground reality. Actually, the experience may increase, good or bad, but definitely the newer thoughts, the newer concepts, the principle behind using this or the other, it's so kind of mixed up at the current point in time. So we, dear friends, are toying with an idea of putting our thoughts together to help the clinicians, the word Vidya used, groom themselves into a good quality, fine cadre of IVF and ICSI or ART specialists, if I may say. They may have the necessary documents to get the unit started, but the better they are, the more they learn, the more they get wiser as to why they're doing whatever they're doing. With that, on behalf of KASOGA, which is the state chapter of obstetricians and gynecologists, on behalf of the KCOG, which is the Karnataka College of ONG, and on behalf of ARTIST, which is the Asian Research and Training Institute of Skill Transfer, the entire team is here, and the Shield Connect, which always helps us connect beyond the geographical boundaries. Once again, with Professor Gelal's very kind gesture of the Namaste, we thank him once again for being here with us on this fine evening to enlighten us and learn more. Thank you, Professor Gelal. And next time, we do hope to see you in person in our own country and have many more delegates. Yeah. Yeah, Vidya?
In Bengaluru.
In Bengaluru, yes. That is the specific part where Vidya and myself live. So we want your entry to India through Bengaluru, which is our garden city, and we do hope to scope pan-India with the first foot in our own city of Bengaluru. Thank you so very much, Professor Galal. Namaste.
Thank you so much. Thank you so much. It was my pleasure actually to join you and hope for more collaboration. Thank you so much.
Sure. We will keep in touch on the mail and bounce some ideas with our team here, and just kick started with whatever is possible as the first crucial step, and then we will build the layers over it. That is our pledge and promise on this evening of the KCOG International Speaker Series program. Thank you again. Namaste.
Thank you, madam. Thank you so much.